Some of us literally go back decades. So I'm going to jump in. I've got no conflict of interest to disclose. Next. Objectives: learn about the current opportunities and challenges in providing comprehensive relationship-centered care coordination during time of constrained resources and heightened acuity of need. Discuss potential advantages and challenges to communication and trust created by the shift to remote technology-based care, and describe strategies for providing care integration services that are family-centered, responsive, culturally sensitive, and grounded in relationship in the virtual environment. Next, please. I'm going to go through these slides pretty quickly because I want to make sure that my colleague Christina Boothby has a chance to build a bridge for what is happening on a broader scale. And by design, everybody, some of these slides, some of you have seen before, and that is intentional. I want to let people know that virtual care may be a novel tool, but it shouldn't take our eyes off of what we're trying to do for children with medical complexity and children and youth with special health care needs, which is measurable, high value, sustainable care coordination. So with that, I'm going to quickly remind us who are the types of children, youth, and young adults that take our attention. At the top of this complexity pyramid are about 1.5% of the population. They use 40% of all of the dollars spent. You can see neurodevelopmental disabilities, including autism and autism with comorbidities, significant behavioral psychiatric conditions, sickle cell, hemophilia, and other oncologic conditions, technology dependence, multiple chronic conditions, health-related social needs, including poverty, racism, and adverse childhood experiences. The middle of the pyramid, also kids with special health care needs, but a little bit less complicated, and they comprise about 25% of the pediatric population. You'll see at the top of that list also is behavioral conditions, tend to be single conditions: ADHD, attention deficit disorder, post-traumatic stress, depression, anxiety, asthma, obesity, etc. And really those 25% of the kids, the top of the pyramid, is about 90 to 94% of all the cost to pediatric care in the United States. I'm excited to share with you that this was published in a report supported by the United Hospital Fund around value-based payment models. And I want the listeners here to be thinking about value-based payment because we have an opportunity right now and going forward to sustain this work. Next slide, please. So the difference between care coordination and integrated care. Integrated care is a seamless provision of health services from the perspective of the person, the patient, and the family. In other words, it's a patient-reported outcome, if you will. Results from coordinating the efforts of all the providers, irrespective of institutions, departments, community-based organizations, disciplines. So the family, the patient, the caregiver unit can perceive that all members of the care team are working together on their behalf. Care coordination, Dr. Renee Turchi and I were embedded this in the 2014 AAP policy statement on care coordination. It's the activities in the space between visits, providers, hospital stays, and it's the co-creation with the patient, the family, and the implementation of a plan of care. So activities, care coordination, integrated care, patient-reported outcome. Let's move forward. These are the domains of integrated care. This was designed to harmonize with the World Health Organization's person-centered integrated care framework. So this actually is being implemented around the world right now. There is the caregiver, person, patient, and family experience, talked about integrated care as an outcome, care coordination activities, needs assessments, development of a plan of care, tracking implementation. We also look at utilization and financial outcomes, including total medical expense, admissions and readmissions, emergency department utilization for ambulatory primary care sensitive conditions, and then finally, provider experience. Next. So again, people have seen this slide, but I know that I haven't gotten to virtual care yet, but that is my intention. Let's just focus on what's the value of care coordination. This is a subspecialty clinic here at Boston Children's Hospital, our spina bifida clinic combined with our bladder exstrophy clinic. And we looked at the activities of non-billable, often non-face-to-face care. So this predated the pandemic. But basically, it shows what does the work of care coordination look like and what are the outcomes. And in fact, we looked at 577 encounters in these clinics, primarily encounters driven by families calling into the clinic and nurses and or nurse practitioners providing an assessment and a plan of care implementation. And what were some of the things that unnecessary encounters that were avoided? Unnecessary visits to the urology clinic, unnecessary visits to other subspecialty clinics, avoidance of unnecessary emergency department utilization, and even for some of these patients with spina bifida and or bladder exstrophy, avoidance of unnecessary admissions. So there's real value in non-billable, non-face-to-face encounters. Next slide, please. When we developed that integrated care survey, the PICS instrument, we did a research project with families, and we said to them, so how would we improve care in the domains of care integration, which we have discussed? And without using the words, families said it would be nice to have a roadmap. Who is responsible for what by when? We call this an action grid at Boston Children's Hospital. It's freely available in the public domain. It basically is co-created with the family and the patient as developmentally appropriate. What's the goal? What's the action to achieve that goal? Who's responsible for that action? What's the time frame? And what are dependencies and contingencies? Families love this tool. They have a clear line of sight, a map, if you will, from point A to point B over time. I've got permission from our chief of genetics and genomics, Olaf Bodemer, at Boston Children's, and they're able to organize multidisciplinary care planning activities with this action grid. It gets shared with the family, it gets put into the patient portal so families can then access it directly and share it. So the goal for us strategically, since the moment we went to virtual care at Boston Children's, was to show the added value for all of the stakeholders that you can see. And in particular, our early qualitative work experience, and we're amassing some quantitative data, is who are the patients that benefit the most? What are the circumstances? So patients with access issues around transportation, significant behavioral health needs, and care management for patients with complex needs whose services are coordinated, already exist within a plan of care, that action grid, for example. And so we're finding that when families have a trust-based relationship with member or members of the care team, and especially if there is a path forward, action grid, a map, if you will, that in fact virtual care is highly attractive for these families and for the providers. Next slide, please. This is from our virtual visits program in our innovation team at Boston Children's Hospital. You can see how quickly the world changed. The bottom of this shows the monthly virtual visit volume from February to now, 35,000 visits per month at Boston Children's, including subspecialty providers and especially behavioral providers, as well as primary care providers. Next slide, please. So capturing the value of virtual care management. We've modified our care coordination measurement tool to reflect the activities that happen within a virtual encounter. It's care coordination. Remember, the CCMT, the care coordination measurement tool, captures the activities in the space between. The CMMT, the care management measurement tool, looks at what are the activities within the virtual encounter. Next slide, please. And so this gives you a representation in our complex genetics clinic, conducted health literacy education on virtual encounters, developed a new plan of care. So imagine being able to document the creation and or modification of a plan of care. We specifically built that into this model because payers, Medicaid and commercial payers, are looking for evidence that the development and tracking of a plan of care is a strong signal to track value, especially for patients with complex needs. A lot of activity around providing guidance for family support for the behavioral psychosocial needs, mitigation of risk for COVID-19. Assessment of the home environment is really, really important, but it's also a potential trust issue. So sometimes families are a little anxious about having members of the provider team peer into their home, but for the most part, we're finding that the providers really like that, and the families, when there is that basis of trust, really appreciate the fact that a clinician can let them know if they've got the right durable medical equipment and supplies, for example. Next slide, please. This is really cool, and I've experienced this in my own clinical work. I've also used this in models of transitioning from pediatric to adult care, this multi-provider encounter. So we're tracking the ability using a virtual medium of having a family meet with more than one member of the care team. A month ago, I had an adult urologist, a 34-year-old patient of mine for whom I am the primary care provider, had an adult urologist, the pediatric urologist, the palliative care team, the families, the patient himself, and we were able to accomplish that in the virtual space. So these multi-provider encounters are supported quite well by a virtual platform. Next. Is virtual care easier or more challenging? And we are asking using our tool, and we're getting a very strong signal about the ease of use. So there are operational issues, there are technical issues that need to be worked out. Clinicians have to start protecting a certain amount of their time for virtual care versus face-to-face care. But this is a powerful tool. Next slide. Again, from our digital health accelerator program. I won't read all of these quotes from families. You will have access to the slides. You can see them. We thought the virtual visit was more convenient and still very effective. This was by far the best way in which we could experience access to care. This was amazing. The doctor was fantastic. Please keep doing this after the pandemics. For so many routine things, this could be a way to cut office visits in half. And it goes on and on and on. And there are companion observations made by the provider staff as well. Next. So innovation in care delivery. This part is really exciting for me to share with you. We're starting to develop hybrid approaches for virtual visits. Our division of genetics and genomics actually is enhancing access. A virtual visit sets the stage upon a referral from a primary care provider or another subspecialist and they're able to see the patients more rapidly and make a determination about whether an in-person visit is necessary, and or whether genetic testing can be done prior to or after a visit. So we're working on updating these models to include a virtual component of the episode of care. Next. We've got some real interesting results to share with you. The New Balance Foundation is supporting an integrated, a community-based integrated care weight management model. My colleagues, Maria Swartz and Kara Ebeling, and I built a model of care integration where we're leveraging trusting relationships of families with their primary care medical home. The initial work was focused on highly vulnerable, underserved populations, the towns of Lawrence, Massachusetts, Lowell, Massachusetts, and East Boston. At the time that this slide was created, in fact, Lawrence had the highest per capita in the Commonwealth of Massachusetts for COVID-19. During the pandemic, the first wave, and in the period of time where essentially primary care was shut down across the Commonwealth of Massachusetts, families were still using this virtual care model around behavioral guidance as obesity specialists linked through the trusting relationship with the medical home. And we've got primary care providers asking to participate in this model as well. Next slide shows you some of our early findings. We're able to use virtual connection right through the pandemic. Quite honestly, to this day, they continue. We're seeing reductions in BMI. We're seeing increased scores around fitness. Early results are showing improved quality of life, and we're using the validated family experience of care integration to track this over time. Next slide. So what effort is devoted to care coordination? Assisting with identifying appropriate resources to address household food needs, food security, connecting families with additional community resources, discussing participant progress with the community partner, and linkage to the medical home. And nearly half of all the activities of care coordination using the tool that I've shared with you had addressed COVID-19 and the implications for this vulnerable population of high BMI children, which, as you know, is one of the risk groups for COVID complications. Next. Now, this potential for disparities abound. We have to be mindful of the so-called digital divide. We have to use measurement, including stratification of performance measures, in all of the work that we do. Race, ethnicity, language, disability status are all really important as we start to look at performance against common Medicaid and national performance measures. The infrastructure is crucial. We need human capital. We need to figure out how do we train people, and we need to have technological interventions to help bridge that digital divide. Next. In partnership with the American Academy of Pediatrics, the second edition of the care coordination curriculum is freely available. Open Pediatrics is a free technology platform. Our partnership with the National Resource Center for the Patient and Family-Centered Medical Home at the AAP has been a long-standing partnership with MCHB funding. This tool is available and includes all of the tools we've talked about today. Next. All of our tools are free in the public domain. Here's the website link for that, and you once again can see our tools, access them, and reach out for technical assistance. Next. And I think it's to you, Christina.
Yes, thank you, Rich. So when we were planning this presentation, we thought it would be helpful to provide a high-level overview of a broader national initiative that's going on right now related to telehealth and virtual care. And the AAP specifically received CARES Award funding from HRSA, MCHB, HRSA, along with 3 other organizations, including AmChip, Family Voices, and University of North Carolina, to really um, um, increase access to care via telehealth to families. So the goal of the AAP project is to improve implementation, utilization, and access to telehealth care for all children and adolescents, with a focus on the needs of specific areas of care and populations, including children and youth with special health care needs, adolescent health, behavioral mental health care in rural and underserved communities. And all of our work is really grounded in the medical model of care, and we're approaching all of our efforts from a systems and health equity lens. Next slide. So as we were thinking about this presentation, we thought it would be helpful to share some of these high-level preliminary findings from a fairly comprehensive needs assessment we conducted as part of our CARES Award on the gaps, challenges, and opportunities around telehealth. So we conducted the needs assessment in 2 phases. The first phase um, was a review of, included a secondary data analysis and review of over 100 data sources. And then we also conducted surveys with our national advisory group, key informant interviews with clinicians, and focus groups with multiple stakeholders, including families and caregivers and young adults. And these are some of the preliminary findings. We found that 37% of clinicians, only 37% of clinicians received telehealth training since the onset of COVID-19. Clinicians mentioned that the resources they needed most related to telehealth included materials in multiple languages for patients and their families, promising practices, use cases, and case studies, and technical assistance around telehealth. The barriers they mentioned were lack of access to technology, including equipment and broadband among patients and families, insufficient payment for telehealth services, and inability to bill for certain services. Next slide. Some of our preliminary findings from our key informant interviews and focus groups include that patients are accessing telehealth most often for mental or behavioral health, as well as chronic care management. And I think this aligns with some of the data that Rich shared as well earlier. And patient and family receptivity to telehealth is highest for those with chronic or behavioral health conditions, and that there are multiple disparities in access to telehealth, which may be based on disability status, socioeconomic factors, race and ethnicity, language proficiency, and technology access. Next slide. So I knew I didn't have a lot of time, so I just picked one little area of our CARES Award to focus on. So since this presentations is focused on care coordination, that's what I picked, but this is just a very small component of our overall CARES Award and all the activities that we're doing. We're planning multiple online educational modules and other resources for clinicians around telehealth. But we are partnering specifically with Boston Children's Hospital to create some care coordination resources, which includes development of criteria to define emerging and promising practices related to virtual care coordination for children with special healthcare needs and CMC. Identification of 3 to 5 emerging practices in the delivery of care coordination, and then a creation of a new case for the pediatric care coordination curriculum, 2nd edition, that Rich mentioned earlier, that really builds capacity around care coordination. So Amy, I'm going to turn it back over to you for any questions.